So thank you very much. I'm excited to talk to you today about patient safety in graduate medical education. And as I listen to my colleagues, I recognize a number of themes that are very prominent in graduate medical education. And so I think you're going to see a connection through all three talks. I'm from Mount Sinai Health System in New York City, in the Icahn School of Medicine at Mount Sinai, and I'm excited to be here. Trying to advance the slides, but the green button doesn't seem to work. Yeah, it doesn't seem to work. It's not working. Oh. In the middle, it's not working. I'm pressing it. Yeah. Okay. Talk amongst yourselves. I haven't said anything yet. The talk is great. Oh, here we go. Okay, it's back. Okay. So here are my learning objectives for you. By the end of the talk, I want you to be able to describe the role of patient safety in graduate medical education, list current challenges in patient safety education, and apply approaches to increase resident and faculty engagement in patient safety. I have no disclosures. So I'll tell you a little bit about my work environment, the Mount Sinai Health System in New York City. We are a health system of 8 tertiary care hospitals in New York City and 400 or so ambulatory practices. Our medical school is the Icahn School of Medicine at Mount Sinai. We sponsor 148 residency and fellowship training programs across our system, and those programs are training 2,300 residents and fellows. And according to the ACGME, we are the largest graduate medical education sponsoring institution in the United States. Just by way of review, I'm going to talk about GME. And so the definition of that for my talk is GME in the United States. So as many of you may know, undergraduate medical education in the US, we call UME. That's really medical school, 4 years where people earn their medical degree or a DO degree as well. When we talk about graduate medical education or GME, we're talking about residency and fellowship. And this is not just internal medicine. This is, in any specialty, radiology, orthopedics, et cetera. It's the same general schema. So when I say GME, I'm talking about physicians who have graduated medical school, some of whom have a license already, who are continuing their training on the job, so to speak, under the supervision of board-certified faculty. And I'm going to use the word residents throughout. And when I say that, I mean residents and fellows. It's just easier to use one term. So let's talk about patient safety in context. We'll start broadly, and then we'll focus in on what it means in graduate medical education. So in their sort of seminal report that many of you are probably familiar with, Crossing the Quality Chasm, the Institute of Medicine, which was the name at the time, defined 6 domains of healthcare quality, and you can see that patient safety is really at the top there. And I think this is pretty, widely accepted. It's a good framework. It makes a lot of sense. I think we would all agree that these are good parameters for quality of care, and safe care is right up there. More specifically, in graduate medical education, the Accreditation Council for Graduate Medical Education, the ACGME, is the organization in the United States that sets educational standards for training programs and also monitors and enforces them and grants accreditation or not to training programs. So the ACGME has described 6 key elements of the clinical learning environment through their CLEAR program. That's what they call it. And you can see number 1, of course, is patient safety. And the others it sort of mirrors somewhat, the IOM definition, but you can see the others there. Now, I will point out that there's a lot of overlap here. Certainly supervision is integral to patient safety, and certainly teaming is integral to patient safety. But in GME, we sort of parse it out as a separate topic. So focusing even more specifically, the ACGME sets standards for training in the United States. Now, of course, it may be different in other countries, and I'm talking about, the United States because that's what I know, but I hope that as we go forward in the talk, you will perhaps see some themes that might be present in your country, in your setting, and hopefully, some of this will resonate with you and you can get some ideas on how to implement them or address them. So what do residents and fellows need to know or do in the United States? They need to know what types of safety events to report and how to do that. They need to receive summaries of an institution's safety reports. They need to participate in root cause analyses, which is a formal exercise to understand the root and contributing causes to an adverse event. They need to design and implement corrective actions, and they need to disclose adverse events to patients and families, and that can be either real or via simulation. And these are the requirements for all residencies and fellowships in all areas of medicine in the US. So in addition to setting standards, as I mentioned, they also enforce the standards and monitor how programs are meeting these standards. They do that with a series of site visits. They come to institutions and they talk to a group of 30 residents or a group of 15 fellows. They talk to 15 nurses. They're actually not so interested in talking to hospital leadership. They walk around the floors. And that's how they understand if a residency or fellowship program is meeting its responsibilities. At their most recent national report of findings in this area, which is from 2021, which is based on site visits and interviews with trainees at 566 institutions across the United States, which is essentially like 93 or 4% of all of the training institutions in the US. These are the three themes in patient safety that they identified as challenges. Residents do not report adverse events frequently enough. They don't understand how event reporting leads to improved systems of care. And residents and faculty do not participate in investigations and analysis of adverse events. And so I don't know, how much of this applies in other countries. Certainly, I would agree with this finding. We have these problems at Mount Sinai. There's no question. These are tough challenges, and we're doing all sorts of things to try to address them. I'm going to share some of our work with you. But first, let's take a step back. So a lot of the focus is on reporting of adverse events. And my colleagues, Dr. Astek and Dr. Singh, also mentioned reporting as important. So why is reporting of adverse events important? Well, this is a sign we see in New York City, which is where I live, in the subway. I think that other cities in the world probably have something similar, right? And this is an appeal to the frontline users of the subway system, if you will. This is an appeal to regular people, citizens, who use the subway, saying, hey, you know what? If you see an unsafe condition, if you see a threat, if you see an accident waiting to happen, say something, tell us. And this campaign actually is an international campaign. It has shown to bear fruit in terms of identifying unsafe conditions. And so if we look at healthcare, who's closest to the work? Who are the frontline people in healthcare? Certainly residents and fellows are in that group. They're very, very close to the very granular frontline work, as well as nurses and other staff. Attending physicians sometimes are doing direct care, but sometimes, especially in a teaching setting, they're in a more slightly removed role, in a supervisory role. And then you have hospital leaders, okay, who aren't really on the front lines. And so we need residents and fellows and everybody else on the front lines to tell us where the threats are. Where are the accidents waiting to happen? Where are things going wrong or about to go wrong? James Reason, who's one of the seminal thinkers in patient safety, who sort of defined the parameters of a safety culture, writes very nicely about how event reporting is really one of the pillars of safety culture. The Joint Commission, which is a regulatory body that accredits healthcare organizations, hospitals in particular in the US, requires that hospitals have a reporting system for what they call sentinel events. And then there are many states, I live in New York, and it's certainly true in New York, but it's true in most states, that many states also have a mandatory reporting requirement. And so this is all recognizing the same theme here. So just to review, what do we want people, residents, fellows, nurses, attendings, and everybody else to report? There are really 4 types of safety events. Just to review them here quickly. Starting from the left, there's the hazardous condition, right? An example would be labels on 2 medications. They're very similar, and they could easily be confused, right? This is an accident waiting to happen. This is what we call a latent error. It's out there. It's in the medication drawer. It's right in the OR. I've done many root cause analyses on these, right? These things look exactly alike in these plastic drawers in anesthesia. It's just waiting there to be mixed up, right? Next would be a near miss. For example, an order is written for too much metoprolol, but the pharmacist catches the error before the patient receives it. Okay, so the error does not reach the patient, it's intercepted. Nobody carries out more near misses than the pharmacists. We've all gotten the call, hey, Dr. Steinberg, you sure you meant to order 1,200 milligrams? Didn't you perhaps mean to order 800 milligrams? Oh yeah, thanks a lot. That's a near miss. That's a near miss. That's the same thing, right? So the pharmacists are doing this all day long, intercepting errors. Then there's a no harm event, right, where the patient actually receives too much metoprolol, but suffers no ill effects at all. This is also known as we got lucky, right? And then there's the adverse event. Patient receives too much metoprolol, requires an emergency pacemaker. For bradycardia, goes to the CCU, right? So where are the golden opportunities here? What do we want residents and fellows to understand as the best value in reporting? It's on the left. The hazardous conditions and the near misses, because there hasn't been any patient harm yet. That's a chance for us to intervene. So there have been multiple studies to try to figure out why residents don't report, and they're remarkably similar, and here are the themes. They say, we heard some of these from my colleagues, they say they have no time to report, the reporting system is hard to use. They worry that they cannot report anonymously, some systems don't allow that. They think it's not their role to report, they don't know how to report, they get no feedback on reports, they don't understand why reporting is useful, and they're worried about being punished. And so if you're going to improve reporting, you have to address probably all of these, and we're always trying to, make efforts to address different ones that are listed here. So this is our adverse event reporting system. It's called SafetyNet. Is it easy to use? No. Just reflecting back on Dr. Astik's comment. We try to make it as easy as possible. It is online. It's on every desktop in our entire health system. The icon is right next to where people log on to their electronic health record, or where they log on to the internet, or where they log on to their email. We put it there just so it's visually available. You can report anonymously. The first field you can see on the bottom is, do you want to report anonymously? And if you say yes or no, and then it takes you through a menu, admittedly a bit clunky, to describe the event. In our system, these are reviewed by leaders in quality and safety around the health system every 24 hours. This is like my daily routine. I come in, I get my coffee, I review the reports for the hospitals that I oversee, and safety staff work together to figure out what the approach is going to be. So that's our reporting system. I'll describe a little bit to set the stage as well. This is our serious adverse event process. Those of you familiar with patient safety will recognize this as very standard. We follow the RCA2 root cause analysis squared document, which is sort of the Bible, if you will, of how to conduct patient safety investigations. And so when an event is reported into SafetyNet, then we do a debrief. The purpose of the debrief is to establish what happened in the event. So we get everybody who was involved, all the frontline providers, we get them in a room or on a Zoom call these days. And while their memory is fresh, in a very supportive, non-judgmental way, we have them tell us what happened, because we need to establish a timeline. This is an essential complement to a chart review. I think you can all imagine, you can look in Epic or whatever your electronic health record is, or you can go through charts, but that's not good. The chart doesn't tell you the whole story. It doesn't tell you what people were thinking. It doesn't tell you the conversations they had. It doesn't tell you why things made sense to them at the time. And so that's what the debrief helps us with. We take that forward to a root cause analysis where we have content experts and trained faculty in patient safety methods, and we try to identify the root causes, and in other words, why did this happen? We take that forward to a safety solution meeting, which is where we come up with corrective actions to try to prevent it from happening again. And in the box on the bottom of the slide are some of our sort of first principles as we go through this process. We focus on identifying system drivers of adverse events, because that's really 90% or something like that of adverse events are really driven by systems issues. People are sometimes on the, as they call it, the sharp end. People are on the front lines, and so these manifest through people's actions. But what we know is that it's usually systems issues at play. That being said, this doesn't mean that people aren't held accountable. You're held accountable for your choices if you make a risky choice or a bad choice, but you're not held accountable for unintentional human errors that are triggered by systems factors. And this is a principle called just culture, which is like an hour-long talk in and of itself. But I'll just tell you that we follow a just culture. So we'll talk about some of our efforts to improve reporting. So like with anything, if you want to improve it, you got to measure it. And on the right is a graph of our resident and fellow safety net reports for the year 2021 by site in our health system and then for the whole health system. The punchline here is that in 2021, there were about 93 safety net reports of adverse events submitted each month by residents. Now, probably more were submitted anonymously. The ones that this data captures is when the resident logs in and identifies themselves as a resident. So most residents report anonymously, so it's probably more. The bad news is, however, we get thousands of reports every year and many hundreds and hundreds every month. And the resident and fellow reports make up a very small percentage of that. And that's a metric we're trying to improve. You'll see that March was the highest bar. That's because every March is Patient Safety Week in the United States, and we do a reporting challenge where we offer Apple headphones and such for people who submit reports, and they submit reports. We can't do that all year long, but that's the spike in March. So some of the things we're doing, we're training our clinical faculty to lead RCAs. And this is not a chief medical officer. This is not some administrative doctor. These are cardiologists. These are radiologists. These are emergency room physicians who become what we call RCA committee chairs around our health system. We train about 40 physician faculty across the system each year through an annual course, which delivers classic patient safety topics, which are listed there: root cause analysis, high reliability, Swiss cheese model of system accidents, which is the graph on the right, the 5 whys method of trying to get to the root cause of something, and then just culture, as I mentioned. And so this is one way we engage our faculty. Another way we engage our faculty, in addition to training them to lead root cause analyses, is we try to encourage them to just simply attend root cause analyses. And we are able to do that by granting continuing medical education credits to faculty who attend real root cause analyses. So in the United States, virtually all states have a requirement that to maintain your medical license, and in many cases your hospital privileges, you need to acquire annual continuing medical education credits, and you get this through various trainings. Now, we're not teaching people they're not getting CME for a course in how to do a root cause analysis. They're getting CME credits for attending actual root cause analyses, and so we're doing sort of on the actual RCA training. And it's been pretty successful. This is something we presented at the Society for Hospital Medicine annual meeting last year, and it's been sustained. We're granting a lot of credits across many departments, and so it's always nice to give CME credits to your faculty. Something else we're doing, so we offer a resident simulation workshop for internal medicine residents in one of our programs at Mount Sinai Beth Israel, one of our sites. So this is based on a real case that happened at Mount Sinai Beth Israel. A patient got an insulin overdose. They got 40 units of insulin instead of 4 units. And the answer is that what actually happened is that there was, in the medical record earlier, before this error, somebody used a prohibited abbreviation, the abbreviation U for units, which is a Joint Commission prohibited abbreviation, just for this reason. And so what happened here, 4 units of insulin, which is what the patient took, was misread as 40 units of insulin. That's what the patient got. They ended up on a glucose drip in the ICU. So it's a 60-minute workshop. We give them a process map. They have to, which is on the right, and they have to go through the process map and figure out, what happened. It's sort of a mystery. But what they learn is how to identify the root causes, and then we ask them to propose corrective actions. So it's a very, very well-reviewed experience. In addition to simulation for the residents, we also have residents participating in actual root cause analyses across our health system. We train 40 to 50 residents each year. They receive the same training as a faculty root cause analysis chair. And each resident attends about 8 of these per year. You can see some of the feedback from residents who have done this, a great educational experience, learned how to put interventions in place to prevent it from happening again, will guide my future practice, meaningful way to examine systems factors, very beneficial to see the process. And so, experiential learning is really, the best way for people to internalize these principles. And what we want them to understand is what's on the right hand of the slide there, that it's usually systems mechanisms that result in individual failures. We also offer a patient safety elective. This is a dedicated 2-week experience. The resident who applies has to be approved by their training director. They go through the training, they attend debriefs, root cause analyses, they're mentored by faculty, and they do readings and reflective writings. There's an online curriculum, which is pictured at the right, and then there's a little assessment test at the end. This has been popular too. I think one of the most important things that we have done, just referencing back to Dr. Astik's comments about M&M, is we are trying to revise the traditional M&M conference. And so here's the traditional model for morbidity and mortality conference, which some of you may recognize. It may trigger some PTSD, depending upon what your experience was. But so an adverse event or a case with a poor outcome, an unexpected mortality happens, and then this is just discussed, in a large group discussion with residents and faculty all together, and people are throwing out theories about why this happened and what should have happened. And, not all the time, but much of the time, this ends up focusing on individual actions. There's little discussion of systems factors. Participants can often feel ashamed and embarrassed, and it's really a punitive, negative kind of setting, and it doesn't give the right message to trainees. I certainly remember some of these, and they're not pleasant experiences. Instead, this is what we are trying to do now. So you have a case, an adverse event. This case is reviewed by a faculty member in the department who has training in patient safety. Now, at this point, individual practitioner issues in the case are handled separately. They're handled with one-on-one counseling by the division chair, the chief. So let's say it was a diagnostic error, as was just discussed, by Dr. Astik, right? That clinician doesn't have to suffer through a large 1-hour conference and be made to feel embarrassed about the mistake that they made. This happens in a one-on-one setting. We also have a peer review process, which is very, very measured and very, very fair. The systems issues are what are brought to the group conference. And so you have a room full of faculty and residents and fellows discussing systems issues, and the individual issues are handled somewhere else. And this, we're trying to change the paradigm here and let people know that, at least in our view, this is the way systems or individual practitioner issues should be handled. So we do a few other things just in closing. We do an educational conference every year. There's always a safety track. We give a consistent stage to patient safety. We publish a newsletter where we highlight patient safety projects that residents are doing around the health system. We also do really nice interviews with patient safety leaders to try to inspire our residents and fellows to dig deeper into the area of patient safety. And I'll finish with this concept of unsafe behaviors by residents. So here are 5 things that I can tell you have led to adverse events because we've done root cause analyses on each of them, right? Copy and paste in the EMR, poor hand hygiene, rude behavior, poor team skills, not calling for help, overconfidence, that was mentioned by Dr. Astik. So here's my question to you. Where do residents and fellows learn these behaviors? From us. Right? They're not taught in medical school. They may see them in medical school, but that's not what they're taught, right? This is the hidden curriculum. They're observing and taking everything in. Who are they observing? Yeah, they're observing their peers, but who are their peers observing? The faculty. And so role modeling is really more essential than almost anything else. If we want future physicians, the future leaders of healthcare, to embrace a modern view of patient safety, we have to role model it, okay? So you can't be a physician these days who, I just do my procedure, this is something new that they're talking about, I just do my thing. That's a really outdated concept, okay? We have to take center stage with our role modeling, and that's how patient safety education is going to succeed best. Thank you.